All right, everybody, thanks. So today, this is a two-parter. I started to do it as a one-part. It would take a really long time. So we're going to talk about fascia and its role in function and training. Um, Fascia is a everybody in this conversation's heard of fascia. You may understand it somewhat better than others. But I think what I'm going to do is just go over basic biology today and talk about what it is, where it is, what it does, and what dysfunctions in the fascial system can do uh, to normal movement patterns and progressing to higher level movement patterns, and why that kind of happens. So a lot of my talk today is taken from talks where I've seen people. You may know who Thomas Myers is. He's written the book Anatomy Trains. I've seen him speak 3 times. I saw him in 2010 and 2011. That should be an 11. And then I went to a 2-day seminar with him and Robert Schleep, who's a fascial researcher out of Germany, back in 2018 in Boston. The Steckos are the people who are leading the way in fascial dysfunction treatment. Luigi is a PT. Carla is an orthopedic surgeon. His daughter, Antonio, is his son, who is a physiatrist. They're out of Italy. They're doing a lot of dissections, looking at the force lines of fascia and how they correlate to long chain anatomical function. They're also doing ultrasound studies as well as MRI studies showing what happens when you have a fascial dysfunction. A couple of great books that, if you're interested in anatomy trains, is in its 4th edition. That's a good kind of baby step book. It's written for a person just kind of dipping their feet in this. The more compendium-like Fascia, the tensional network book, is co-authored by a bunch of people. And there's many different chapters. Both are great references. There's some other ones that are deeper dives, but I think if you start here, at least with those two, you can get a good foothold on what's going on. So just a quick definition of fascia. Even as a young therapist and even younger athletic trainer, I always just thought fascia was the big densifications that happen in the thoracolumbar spine or in the plantar fascia of the foot. And I didn't even really think of the IT band as being a fascial thing, but babies are not born with an IT band. IT bands are developed when we start to weight bear and put weight through the lateral strut of the tensor fasciae lata, the glutes, and the attachments into the tibia. So it's almost like a weightlifting callus on your hand. It's there. It's pretty inert until you start to put force to it, and then it starts to develop stress lines and adaptation to that stress that allow these things to be more well seen. And the same thing goes through your whole musculoskeletal system, not in a super predictable fashion, but a relatively predictable fashion along many lines. It's really anything in your body that's not a cell in the musculoskeletal system that is fascia. It's fascia technically has to be seen by the naked eye, and I'm going to go over this in a minute. But if you keep at the muscle cell level, there is the same substance in contact with the muscle cell, but can't see it for the naked eye. So the powers that be said that's really not definitionally fascia, even though it's the same material. But it's kind of everywhere. It's in all organ systems. It's basically what kind of gives us shape. And from our perspective, it's really kind of, we need to really understand what's going on with it when we're looking at the movements of ATG and the movements that ATG is trying to help maximize. So fascia is produced by fibroblasts and mast cells in the body, and it's let me do that. There's fibrous portion, the collagen, elastin, and reticulin, and then there's the colloidal gel portion. These things mix together to make the fascia. Kind of like think of like a fruit salad, right? I don't know. Do you guys in other countries, do you guys get fruit salads? Like it's a big pot of jello with a bunch of shit thrown in and that just suspends there. So if you think of the jello as the colloidal gels and you think of the fruits as the fibroblasts and the collagen components, it's kind of gives you a better visual of what it looks like. It's kind of laying in there. It could be at the bottom, it could be at the top, it could be well distributed, but through training, it does get more well distributed. Um, and then water, of course, is the final ingredient. The water is absorbed by the colloidal gels more so than the fibers. The fibers are generally hydrophobic. The colloidal gels are hydrophilic, but this is what gives fascia its consistency and its ability to um, transmit force, in some instances intramuscularly, go along and contract a little bit depending upon, that's too much of a deep dive for today, but that's what's going on. um, the layers of the fascia, like a fascia is not just this thing, like you have muscle, you have ligament, you have fascia, like a nice cheap anatomical model would show. It's kind of ubiquitous, it's kind of everywhere. So the endomysium is the non-fascial component I was talking about. It covers each individual muscle cell. Um, so it's technically not fascia, but it's the same material. The perimysium covers each muscle fiber, which of course is a group of muscle cells, and the epimysium covers each muscle. But all these things kind of flow together, and fascia can transmit force when a muscle contracts. There's something called myofascial force transmission. They look at a lot in the treatment of cerebral palsy, where you have a nervous system that's creating too much tension non-voluntary in a muscle. And but in athletics, I think it's important too. The healthier the fascia, the um, the more you can generate force through fascia, through muscular contraction, through fascia. That's what's going to give us some tendinous bounce, uh, some increased force with while sparing muscle energy, in the big picture, which of course is kind of what we want. If we can spare more muscle energy for when it's really needed, it's a good thing. But yeah, the endomysium is the inner layer, the perimysium is the cell, the fiber layer, and the epimysium is the external layer. And as another aside, um, basically bones are fascial structures. The only additional um, ingredient in a bone are mineral salts. That's what makes bones hard. And if you've ever done that experiment in high school or another time where you've taken a chicken bone and you put it in a jar of vinegar for about a week and you bring it out, it's now flexible because as mineral salts dissolve, so basically you have a fascial structure without the mineral salts. You almost have essentially almost a tendon. It's pretty darn pliable when you do something like that. The function of fascia is to keep cells in a functional relationship with each other. Tom Myers calls this a metamembrane. And again, it's partitioned but communicative with each other. So it's not like this one. It's not that macro where it's just this one big thing and then this one small thing. It's everybody's morphology is different. Everybody's fascial connections and relationships are going to be different depending upon genetic factors, depending upon what you're doing for training or if you're doing anything at all. And as I said before, it has the ability to transmit loads across and beyond muscular borders. That's kind of the anatomy trains concept, where you don't have a specific muscle that does a specific action. You have a muscle that works in concert with other muscles along those chains. And the anatomy trains concept was where Tom Myers, instead of just dissecting straight down into a muscle, he took this scalpel along muscles and followed how maybe you look at the you look at the rhomboids and their interconnectivity with the serratus anterior, and that interconnectivity with the internal obliques, and that interconnectivity with the opposite tensor fasciae lata down the lateral quad to the anterior tibialis, looping around underneath the foot to the the posterior tibialis, um, and then up through the lateral hamstring. It can get pretty deep when you start to look at these things. Does it mean they all function together like that? Not necessarily. It's just there is kind of a continuum through the myofascia and where these muscles meet. Another big one is if you look at the supraspinatus muscle of the shoulder, when your arm is abducted out, it kind of has a falling in line with your long head of your bicep. Just a lot of interesting looks and relationships. Some might be functional, some might not be functional. Um, and as I said before, it has some contractile abilities depending upon, that's more of a histologic thing. If you look at some of these connective tissue components within contracting muscle, they take on like a type 2 A or B fiber might take on the contractile abilities of a fast twitch or a slow twitch, depending upon the activity that you feed those fibers. It's the same type of thing. Most importantly, it's really a housing for your muscles' proprioceptive development. So the way I like to think of fascia is if you think of like construction, you put drywall up, you hang some drywall, and then you paint that drywall. The muscle would be the drywall. The fascia would probably be the paint over the drywall. But as you know, if you go into a house, you want to have paint on the walls because it adds interest to the house in color, and it adds style. So you need fascia in that muscle, not in exactly the same way, but a similar type of thing to think about. You know, paint is minuscule in terms of volume compared to drywall. And I think fascia is more minuscule in volume compared to muscle for sure, especially with all the contractile proteins of a muscle. But that's how to look at it. We're going to go a little deeper here. As you know, you have the muscle spindles. They lie within that connective tissue matrix, within that fascia, and they're really your compass for your body. You're looking at the which I forget. I think it's 1A fibers tell your body that your muscle is changing in length, and your 1B fibers are the ones that tell you if you stop your arm at 90 degrees, it's been at 90 degrees. They're all, and it's a constant feedback loop in the posterior horn of the spinal column. It's giving information to the cerebellum, and then that's kicking back out. It's a pretty complicated neurological phenomena that happens in real time in split seconds. So you can see how if that extracellular matrix and that fascia gets stiff, those things can't tell your body where you're at, even though you might inherently know where 90 degrees elbow flexion is. The triceps might not know it because it's not getting feedback from the biceps. Now the triceps are either underactive or overactive. And then that information goes back to the biceps through the same channels. And now the biceps has a little bit of motor confusion over long periods of time without addressing those fascial densities. You could have a bigger problem. And a lot of things I see in the clinic as a physical therapist are not what they're written out to be. A doctor might send somebody for something like a frozen shoulder, which is just a stiff shoulder joint, which is more like almost autoimmune. I'm like, if I can gain motion by doing fascial therapy and almost all their motion back in one session, they didn't have a frozen shoulder. They just had a messed up fascial system and its communication with the higher centers in the brain. So it's a really important thing. Those are the spindles. And then you have the more mechanical oriented endings within fascia, like the Pacinian corpuscles, which are stimulated by pressure, the Ruffini endings, the Golgi tendon organs, which are closer to tendon and muscle ending, or where tendons meet muscles, and then the free nerve endings, which can actually cause pain if they get bound down. That's a lot of the referred pain I think we get from fascia. But the big thing here is all these proprioceptive elements are within the fascia, and the fat, and it surrounds it at every level. So as I said before, it's not this thing where here's this fascial layer, here's this muscle, and here's this thing. There are layers to it, and I'll touch briefly on that. But you can see if you don't have a good fascial network in support with the muscular network, you could run into some problems. So mechanics of a normal functioning muscle. This is really baby step Wikipedia abbreviated stuff here, but there's a harmony between agonists and antagonists, and based on what I just said, the fascial expansions help the adjacent muscles respond accordingly too. So it's not just your bicep contracts, your tricep relaxes. Your forearm flexors have to respond to that. Your forearm extensors have to respond to that. Your proximal shoulder muscles and the scapular muscles have to respond to all these things. And these joint receptors that we talked about back in here and even here are all talking to each other based on that. Actually, in your distal, in the retinacular ligaments of your hand and of your feet are the richest areas for the Golgi tendon organs, and those things do communicate. I can't give you the specifics on that now because I don't know if I understand it completely enough yet, but I've taken some Steco courses, and in the part 2 course they talked about that. It was a really interesting thing. And you'll treat one side of the body in the upper extremity, and you might treat the opposite side in the lower body on the opposite extremity to get a response in the soft tissues that you want to get normal movement patterns. But we got to have a mobile and responsive connective tissue and fascial system to deal with the loads that we're putting on through training. And in part 2, I'll talk about ATG and see if ATG meets this criteria. And it's a spoiler alert. Of course it does, because it's the same type of principles that I'll talk about that the fascia people like Tom Myers talk about how to train fascia. Some of the people have jumped on this as well. ATG principles line right up with that all the way through for the most part. But the reason you need that mobile tissue is those cellular organisms don't fly blind. I mean, I don't know how much you guys know about aircraft or not. I have some friends that are pilots, and some of them are instrument rated. And I'm like, well, what does that mean? And when you get into playing with these guys, they take these glasses like this and they put them on, but they have all these blinders on them. So you can't see out the plane. All you can see are the instruments. And they can literally fly the plane based on the instruments. They could land that plane. They could take that plane off. They could change altitude. And here in the US, John F. Kennedy Jr. died. He crashed his plane into the ocean because he was flying in fog and he was not instrument rated. He literally didn't know where that plane was. And if your fascial system isn't mobile, these organelles can't tell your body where they are at a low level. And then you might say, well, it's not like you're paralyzed, you have a spinal cord injury. No, but you just don't get the normal movement patterns that you would get if everything was functioning well. So what happens in fascial dysfunction, an event or series of events that I listed here, just injury, disuse, mobility restrictions, and the like, lead to densification of this connective or fascial tissue. And that's a whole nother physiological thing. But what the Steco people in Italy have done, they've shown on MRI and with a diagnostic ultrasound, you'll go through your fascial levels. You go through your skin, you go through your subcutaneous fat layer, you have your superficial fat fascial layer, you have your second subcutaneous level, you'll have your deep fascial layer, which is where a lot of this stuff is housed, and then you'll have your muscle. Well, if there's a fascial density, you'll actually get a squeezing out of water content, much like if you had a bottle of salad dressing, shook it up, it's together, and you let it sit. There's then layers. There's an oil layer, there's the herbal layer, and then there's the whatever else is in there. That water gets between the deep fascial layer in the muscle. Now the muscle can't communicate with that tissue in concert, and you get these transmission delays, so to speak. So as I said before, as the densities build, normal movement is changed, and then you get this subtle movement dysfunction. And then over time, continuing these patterns, you get these changes in the musculoskeletal system that are more macro. You get tendonitis, you get long-term tendonitis leads to tendinosis. You get one side dominant versus another in a shoulder or a knee, and you get osteoarthritis because of weird loading. I think it's like getting caught in a subtle rip current. The next thing you know, you're way far away from the shore and you're out to sea pretty far. But and then what you do because you're panicking, because you're out, you swim against the current, you end up getting fatigued and you drown. The way to fight a rip current is just to follow parallel to that current, and it brings you back into sea, or it brings you back into shore. And the same way approach is taken when you deal with fascial dysfunction. To train out a fascial dysfunction is a slow, guided process, which again is going back to what ATG is doing. You start at zero, you move toward your progressions. It takes time to get these things to happen. If you're in a hurry, you're going to get hurt. And it's the same thing here. Death by 1,000 cuts gets you the problem. The fix is, treat one cut at a time. So I don't want to get, there's a lot more I can go into with this. And in part 2, I'll talk a little bit more. Hopefully I'll have some more pictures to be able to share with you. But I have a couple fascial models I use in the clinic. This is a fascial pelvis. So we think of the musculoskeletal system, and a lot of physicians do too, even orthopedists. They think, well, bones sit on top of joints, and the meniscus between a knee joint and the articular cartilage is what bears the load. What people in more fascial science would say, your matrix is out there, and your bones kind of are suspended in that matrix through the muscular system and such. So if you look at this model, the members, the struts don't touch the bands, and not one of these struts touches a band. Not one of these bands touches another band. Like the struts don't touch the struts, the bands don't touch the bands. But if I took some weird, if I made this where I snip this band, you're going to get an alignment change on one side, maybe even an alignment change on the other. You're going to bring these struts closer to each other, and if they actually touch, you may get wear eventually, especially if we just take this thing and move it. This isn't the best model for me to be doing this with, but you get the idea. If I just crimp down on any one of these or series of these, I'm going to change things, because in the perfect scenario here, if I move this model, there's a reaction from one side to the other. If I move one side, you get an equal and opposite reaction. So I'm moving my left up. What happens? The right goes back. It's kind of how the pelvis works. One side comes forward, an open chain, the other side rotates and closed chain on there. And with these this healthy system I have here of wires and struts, that's pretty good. If I lock down one side, I wish I had a clothespin to put on here, you get a different movement pattern within here. You might get too much movement in one area, not enough in another, and then you're going to have dysfunction. I also have a fascial spine here, which I keep in the lobby at the clinic. It's the same thing. None of the vertebrae are really touching. You can kind of see. And they're all suspended by the elastic wires. If I cut some of these wires, obviously we're going to have a bit of more of a collapse, and you're going to just make that chain not as healthy. This isn't an exact model, but it's a good idea. It's a tensegrity model. It shows the tension and the compression and the tension balancing each other out. And that's really what we're striving for, isn't it, when we train? So that's what we're looking at. So the big takeaways here, just understand, kind of give you an idea what fascia is, where it comes from. You can have that intelligent conversation with a medical professional or some parent of a kid who's a doctor who says, well, I don't know if this is a good idea because of this. And you can say, well, you know, you're training not only muscle, but we're training the fascial tissues, and healthy fascia leads to a healthy musculoskeletal system. It makes you look a pinch more intelligent if you can discuss these things at a basic level. And then understanding what can go wrong and the cascade of events. And then you just understand that you're training the fascia, but you're not training the fascia at the expense of other things. If you do good training principles, the fascia is going to go along for the ride and get what it needs. You know, some people would say, well, I'm going to do fascial training today. They go down this weird road of like, oh, I just learned this thing about fascia. That means I got to start being a fascial trainer, or they might try to sell themselves as that. Well, you're not going to do that because it's just too, you can't have one without the other. It doesn't work that way. But that said, as a coach, if you're seeing some weird movement patterns, or a person's complaining of pain that is out of line with their typical presentation, you might say, okay, you might have something going on here rather than just a traumatic strain or sprain. Let's get you to somebody that can take a closer look at this. I wouldn't recommend, unless you're a massage therapist or someone with a background in either athletic training or physical therapy, to treat this yourself outside of, like, you know, typical movement prep, foam rolling, some lacrosse ball or tennis ball work that you normally would do. Don't necessarily become a diagnostician in this, but have people in your network you can get people out to. You know, and that's where the team that you have around you is good. You know, I don't treat everything in my clinic. I have a couple of good chiropractors in my network that if you have a spinal issue, I think, you know, an adjustment would really help, or some specific chiropractic work. I have a good massage therapist or two that, you know, they can spend an hour and a half working on the body, and that have a decent understanding of fashion. They might not understand movement principles the way we do, but they do understand the muscular system statically and fascial restrictions, then because they have good hands, and those people can help you make your job easier. So I guess the way I would close this is, I didn't want to do that. Franz, what do I do here, boss? How do I get this thing back up?
Isn't the play button on the right working?
Play. Oh, I see. Yep, there we go.
Okay.
Gotcha.
And then you can just click through quickly if you want to.
Yeah. Yep. 1 second here. Yeah, the last point was more of an analogy. Sorry, guys. Yeah. So I said, treat fascia like a snake in your backyard that you may or may not think is poisonous. You know it's there. You need more information about it. You don't dive deep until you understand a little bit more. If it's a poisonous snake, you don't want to take it in your house and get to know it real well. You kind of probably want to call somebody and get rid of it. If it's not a poisonous snake, it's part of your ecosystem in your backyard. You can just let it be. But you don't necessarily, unless you're really a herpetologist, you don't want to be the guy running around the snake around your neck because everybody's going to think you're weird. If you basically take an idea like that with fascia, I've seen a lot of personal trainers go down this road where they, you know, like, we're going to do our fascial system training today, and it's like, you can't really separate fascia out. You can just knowing good training principles with long length muscle training, with slow progressive movements, things like that, you're going to get it to go. But just understanding a little bit more about it, and not just, you know, if somebody has pain in their hamstring or pain in their hip flexor, you know, it's not just because that muscle has had a problem. There's deeper dives with that, and that's what you're looking at. So in a nutshell, that's part one. Part two, I'll touch a little bit more on some of the relationships between muscle groups and fascial lines, and how that ties into ATG training principles, and maybe even touch on some specific exercises, but it totally goes together with those things. So that's the end of that talk. Do you guys have questions?
So far not. Anyone else having any question, any thoughts, takeaways?
Alrighty then.
Okay.
I got a quick question.
Yes.
Shon, so you were talking about like the fruit salad thing. There's the collagen type fibrous type portion, and then there's the gel type portion. How could you simplify like the explanation of what the gel type portion is and what it does?
That's the extracellular matrix. It's basically the glue that holds everything together. So without that extracellular matrix of, those materials, you're not going to be able to keep those more fibrous components in suspension. You know what I mean? The reticulin and elastin and the collagen won't be able to do their expansive, like they can't sit alone. They need a medium to be in to function, and that's where the colloidal gels and the water come into play. And the colloidal gels are hydrophilic, so they require water to maximize their function to allow those other fibrous tissues to model and transmit force. So the gel isn't necessarily the functional portion. The fibers are more the functional portion, but the gel is there as a medium for them to exist, and then to kind of remodel in that matrix. You know what I mean? If that makes sense.
Yeah, that makes sense. Sorry, it's just like really complicated to me.
Yeah, I don't mean to be blowing people out of the water with this, and I kept this really simple. There's a lot of people, you can go to a lot of podcasts, and there's a lot of people talking about fascia, and I get confused when they're talking. I'm like, man, you're making it worse. We got to really break it down, so if I need to kind of scrub through this again before I do part 2 and answer questions of people that were here, I'll be glad to. So I want to keep it simple, but just know that you hear fascia, know that it's part of your musculoskeletal system. It doesn't exist separately. Yeah, there are areas that get more dense, and like your thoracolumbar fascia in your low back and in your feet in your plantar fascia. But there's areas where it's really spread. Here's how I like to think of it. Are you in the US, Max? Yeah, so think of it like, do you know Route 1? Route 1, US 1 starts in Maine and it goes all the way to Key West, right? But in the middle of Route 1, you could go through a town where there's like 5 stoplights and it's 2 lanes and it's really in bad shape. There's potholes and stuff. And then all of a sudden it morphs into a 4-lane highway for 50 to 100 miles, and it goes back into a 2-lane road. In some areas it's 2 lanes and 1 lane, and it's in good shape. You can drive 70 miles an hour on it, and then you come into where it's 25 miles an hour and there's more stoplights. So it's the same kind of thing, but it's different as it goes down. But it's the same, you know what I mean? It's the same, those fascial tracts are sort of like that. They follow different muscles, but they exit those muscles too, and they go over tops. So Route 1 goes through Maine, it goes through Connecticut, it goes through wherever others. I don't know what states it runs through. I know it starts in Maine, it goes through Pennsylvania, and it ends in Florida. So fascial lines exist based on forces transmitted through muscular contraction beyond one individual muscle. And it has a lot to do with the ability to minimize energy and maximize rebound and bounce in a system of movement. Like, from like the calf, the gastroc soleus through the hamstrings, et cetera, into the Achilles tendon, into the foot musculature.
So just adding onto this question, would this mean if we have two very different types of athletes, so like someone who's like completely throwing and having like a certain rotational load versus someone who's doing like a completely different one, would we like see different like kind of thickness or like, yeah?
Yes, absolutely. Yeah, as Tom Myers talked about it, he talks about Viking fascia and acrobatic fascia. If you live nearer to the equator, I think it's gene expression too. Your hotter temperatures, more exposure to the sun, ambient temperatures, you're going to develop a certain type of tissue resilience. If you live in a Nordic country, you don't have as much exposure to the sun. It's colder temperatures. You're worried about energy conservation more than energy expenditure. Your fascia adapts this to the same way. Just much like an athlete with a thick spine. As Stuart McGill, the spinal scientist, will talk about, you have an oak spine and then you have a bamboo spine. Someone of a smaller stature can tolerate more lumbar flexion. Somebody maybe does yoga might tolerate yoga more, but if you had a USA football linebacker who weighed 260 pounds, they might not tolerate those same positions. That's not saying over time, just training them slowly and progressively, you couldn't get that spine to move better the way we can with Jefferson curls and with back extensions and things like that. You just have to really take your time, and you might realize at the end of the day, the person with the bamboo spine is just going to be better at getting into those positions in yoga. Like any athlete, there's going to be genetically gifted athletes that are more prone to have success in a certain sport versus other. But you're going to see, you'll in a rotational sport, you'll get fascial lines in the obliques. I don't think there's that much research there yet, but it makes total sense. A rotational athlete like Ryan Krauser, the USA Olympic champion, the shot putter, he's 6'8", 3 something, but he's developed the ability to get around that ring pretty efficiently. So if you could get an MRI picture of those fascial lines, I don't even know if MRIs are that sensitive with like the external fascial lines from anterior to posterior. I think they look at the different layers from a ventral cut. I think you totally see it differently. You probably see a difference between a javelin thrower and a shot putter. You definitely would, because it's rotational versus linear.
Yeah.
And those fascial slings become important. He talks about it in the book. I think he has a picture of a javelin thrower. The superficial front line musculature, the pecs and the abdominals, and to some lesser extent the erectus femoris, really take on an aggressive stretch shortening cycle to in the part where before the penultimate part before you release that implement. Whereas a shot putter, they're not winding up, they're just blocking the rotation. It's a completely different movement. So I think you'll totally get different fascial adaptations as well as muscular adaptations. And the fascial adaptations, if it's in good working order, the muscle spindles will give better feedback and quicker action. There's a lot more to this, but this is a basic. If you guys want more than this, I could certainly give you. There's a ton more. I know what I know, and I still don't know a ton, and I'm still trying to refine my elevator speech for my patients about why there's dysfunction, what happens. I kind of have 70% of it down at any given time, and that 30% that I don't have down slips into the 70 and takes the place of something, and it's constantly being. This is just something I think we're getting into at a basic level, and it'll filter into. But the other downside is if you don't understand it, to say, you're going to exclusively just train fascia. You're training fascia no matter what you do. But I think the take-home message is good foundational training is good fascial training and good muscular training.
I just wanted to jump in quickly. Shon, thank you for the presentation. And my question is, what's the impact of scarification, specifically in the form of tattoos, for fascia, sensory mapping, etc.?
I don't know if I know the answer to that. Say it one more time.
The question's in regards to, there's getting tattoos, ink in the skin.
Oh, okay, yeah, okay. I can't, a tattoo artist might actually probably have a better answer there, but like, I think what you're looking at, if you get a tattoo, you're just into the dermal layer, right? You're not going subdermal. Is the ink going subdermally?
It depends how it depends how heavy-handed that tattoo
Yeah,
artist.
I gotcha.
And then the other thing is that, like, it's in the skin, so it's gonna seep through the skin. Like, it's gonna start to go through the layers, in theory.
Yeah, well, I don't know. I mean, how can I make this, Franz? I hate to ask you this. How can I make this thing bigger again?
Hit the plate on the right-hand side.
Hit this. I don't want to make my presentation bigger. I want to make you guys' pictures bigger.
Oh, go stop screen sharing.
Stop screen sharing. Oh, stop share. Oh, got you. Okay, cool. Here we go. Yeah, much better. Yeah. So I'll get this one day, dude. I swear to God, within the next, by Christmas time, I'll have this down where I don't have to ask Franz for help or anybody else. That's a good question, because I had heard an interview with TJ Dillashaw and Joe Rogan. He was talking about arsenic and tattoos possibly getting systemically in your system, but I don't know if tattoo ink can histologically change a tissue like fascia. And I don't know, my son has tattoos. I don't know how much ink, like if you could voluminize the ink that a person has, like, I don't know if there's a way to quantify that. It's a pretty interesting question, but I've not heard that, and I don't think so. I just think, at that level, I mean, the deep fascia is pretty layer. I mean, you have your dermal level, you have your subcutaneous layer, you have your superficial fascia, which is under the subcutaneous layer. So yeah, maybe a tattoo needle gets down that low. I think more than likely you're going to be able to get an acupuncture needle down in there, but a tattoo needle's, I've seen him get work. I mean, those, those needles are pretty fine, and I don't know how deep they penetrate. I mean, he's bled a little bit here and there, but never like gone to a point where he's, that level. So I don't think that's probably really an issue in terms of biomechanical problems. I mean, are there other problems with tattoos that, and I don't, after TJ Dillashaw like totally cheated in the UFC, I don't believe anything out of his mouth right now. So he can tell me about all the arsenic in his system or whatever, but like, I know a ton of people who have tattoos, and I don't know anybody's gotten sick or and actually it makes my job easier. I had a guy who was an Army tank platoon guy, and when I would do fascial work, I'm like, okay, we're going to put this cup at the head. I'll do cupping sometimes. I'm like, okay, the dragon's head gets this cup and this one here, so it was great for me because it was like way less guesswork. He was mapped out for me.
Well, and then the second part of the question is to do with scarification, scarring of the body and the scar tissue, especially, if you've had surgery, how does that affect mapping? And then the other thought that I had was, there's a massive increase in the level of elective plastic surgery, which on one hand creates scarification, and then two, introduces certain external objects sometimes into the body. So yeah. I'm intrigued to know about that too. And then also, the part of that is also that I personally know 3 women here in New Zealand that got got boob jobs done at an era where the quality of the silicon was no good, and they ended up with the leakages and
Yeah,
had severe health-related issues. So
I think those.
I mean, there's a bit there, but
No, I don't mean to interrupt you. I think the silicon issues are more systemic and organ related and hormone related than the myofascial issues. Uh, Not knowing much about implants. I mean, I don't know how they do calf implants or buttocks implants. I mean, breast implants, they're done over the muscle. So you might have some compression in that pectoral area, I suppose. But, that's one of those things that just doesn't get talked. Like, that's not my expertise. I don't know, I don't know if there's any female power lifters who are elite in bench press and they've gotten implants and it's been a plus or a minus for them. Surgery scars, yeah, for sure. I mean, but typically in the areas where they get that, well, okay, yeah. So if you get surgery, you're changing the musculoskeletal dynamic. That specific muscle might get some myofascial adhesions outside of the surgical scar, but you want that scar to heal and be mature, and it's a different type of collagen that's laid down in the scar. So you might not be able to treat that exact place because the tendon that's repaired typically isn't that topical that you can get at it. But again, you get these connective tissue matrix changes along this whole thing because this muscle is asleep at the wheel. Now, if your muscle is not contracting, that fascia isn't moving, and now it's going to densify in those areas. And when it starts to move, it's going to move, but you'll still have those fascial densities, and you won't not get the excursion in that muscle. And you also have communication problems between agonist and antagonist. So that's an area that me as a therapist is I'm going to work on. And I do that all the time. Like if I get a person in who had a surgery, like a rotator cuff, where we're not allowed to really move that thing, but passively a little bit, and we're only allowed to move it a certain number of degrees. Well, I'm not going to go against surgeon's orders and move it more. But I am going to do myofascial work on them. And that's going to take their pain level way down. Because I'm going to loosen some of the connective tissues that are just getting tight. And again, I can't get it. I don't want to shoot an arrow and paint a bullseye around it. I just think you're loose. I just think you're taking tension out of a system. And when you take tension out of a system, other tissues will relax as a result. So that's why massage does work. It's what chiropractic does work. You're decreasing tissue tension. A chiropractic adjustment can decrease muscle tension by 70% milliseconds after it's done. They don't know exactly why, but they know that's the case. Um, I'll just do those. I'll do those things. Like somebody has SI joint pain. I know the SI joint doesn't move a lot. It's like spackling in there. You can't really adjust the SI joint because it's just too thick. I mean, it's a keystone. It's wedged in there. It's got ligaments that are covering it, like literally random pieces of spackle. Like it's like worse than that. I'm not doing it justice, but I know that the sacrotuberous ligament goes into the SI joint, and the sacrotuberous ligament has a direct connection to the biceps femoris. So if I dig into the distal biceps femoris near the IT band, it hurts like hell. But when the person comes off the table, I'll say, how's that SI joint? They say, I don't feel it because I've decreased tension myofascially in that distal biceps femoris. That dovetailed to decrease tension in the sacrotuberous ligament, which was probably pulling apparently on that SI joint in some weird way. I've done that. Now you got to go to other areas too, but that's just before I really had my system and taken the Steco courses. I was like hit or miss. I was like Jimi Hendrix can play guitar. He doesn't know how to read music. He plays a right-handed Stratocaster left-handed, and he never studied music in his life. He figured out how to do it. I figured out how to do my own myofascial work. But since taking the courses, learning a little bit of music, I'm more efficient. So yeah, you can decrease fascial tension like that, and you can and then you restore normal movement and you restore normal fascial integrity within the muscle. It's a fascinating thing. Like it's how much exercise is too much after you do. Like it's a whole. I could talk for hours on this just off topic and talk about the stuff I don't know. But I know, once you restore it, you take the thread away, you recover, you hydrate, you drink a lot of water, you let those hydrophilic components of fascia get their water back in them, then you reintegrate movement. And that's a big beef I have with the fascial. And it's not beef, it's just the Steco people. I've taken 2 courses and I'm actually hosting one here in the US. And the main US instructor said, what are our exercise progressions? He's like, that's a great question. He's like, we don't have a ton yet. We just have treatment strategies. I'm like, yeah. I said, that should be the next thing we look at. What things should we reintegrate so we don't reset that system to be fearful and contract back to, it turn things back on. I've worked on people. I've sent them on their way. I said, yeah, early on, go do what you want. And then they come back a day later. It's like, well, it lasted a half hour. Then it came back because, you want to go home. You probably need to rest a little bit and you need to reintegrate those movement patterns slowly so that fascia can move those neural, those sensory organs can do their job, communicate correctly, then increase repetition, speed, load, et cetera, et cetera. But I don't know what the magic number of that is yet. So not to get too sciencey, but I can dumb it down as much as you want, maybe.
I think, like, in general, this is the thing with fascia. There's so many levels of depth of like understanding you can gain and then apply into the practice. I only had like a very brief understanding, but I was aware that it's quite an important topic. But what, like, I don't know how to say it. What I find interesting is that, like, I come from this acrobatics field, and we oftentimes naturally include a lot of fascia because we have these like huge motions of like the whole body, and are oftentimes working on like this. I don't know if I should call it elasticity or something like this, but if you go into a back handspring and like your whole anterior chain opens, and then as you pull your legs down to jump, it snaps together, like all of these things.
Yeah, that's exactly what it is.
Yeah.
Yeah, and it's all, if you didn't have good fascial mobility and function, you wouldn't be as explosive and you wouldn't be able to get your hands back there. So, you're training these things in concert. You're training your pecs to open up. You're training your bicep to stabilize. You're training your wrist extensors and your joints too. It's all goes together. You're training your wrists to, like, you can't do a I couldn't do a handstand right now. I don't have enough wrist extension. I need to be warmed up and then I can hold it better because you can't balance. So, but it's not just the joints. If you're just going to cram it and stretch the joint, you're not going to, I want to hit that handstand today. If you're in America, it's like, I want it tomorrow. When's my kid gonna have that handstand done? In like 6 months. Well, that's not cool. The other school told me you could get in 2 months. Yeah, he's gonna have injuries through high school and he's gonna crap the bed and not be, like, people want everything in a hurry. Good training takes time and you have to adapt these tissues, because we're not just, if you want to do it that way, you're going to load your joints because something's going to give, and then you're not going to have that tissue balance anterior posterior, and then you are going to then you're going to be on your joints, and then you're going to have a bigger problem. So you want to take your time and mature the soft tissues, which really guide the motion. Do these good things. Yeah. So acrobatics and yoga are great. The people I see who are lifelong yoga people, they're in good shape. I have a woman who has rheumatoid arthritis, and not that gets medical, but like that's a bad disease where like your joints just get chewed up by excessive synovial fluid. And it just you want to balance it, but they don't have that balance. She had both hips replaced, both knees replaced, and she had something called a reverse total shoulder, which is a bad total shoulder to get because they make your ball the socket and your socket the ball because you have no rotator cuff. she's back to everything in yoga. She's slow. She's been doing yoga forever. She's not big. Her body weight's great. She knows what she's dealing with her rheumatoid arthritis, but she responded great because she had those years of building that that fascial musculoskeletal system, connective tissue system up through yoga. I have a 61-year-old woman who has been doing yoga for 30 years. She's amazing. Her posture's great. She doesn't have musculoskeletal problems. She can get in positions that nobody in this picture is, maybe you, but no, I don't even know. Like, she can do things I couldn't dream of doing. So yeah, you're the acrobatic guy. So you could probably say, oh yeah, I did that, like, 6 years ago, but not me. But she's healthy. I'll never see her for physical therapy unless she has a traumatic event. That's why I saw her for, she had a car accident. But, so, and again, so with ATG principles, I'll go over it next week or in 2 weeks or 3, whatever it is. We'll talk about these things. There's no mystery that these things align with fascial training. You're training everything. If you're training the right way, you're going to get that fascia to go along for the ride of the musculoskeletal system. Hopefully I didn't scare anybody here.
I mean, I don't think so, but it's definitely, or it's likely a less sexy topic than maybe like how to get your 40-inch vertical or something like that.
But it does tie into that. And it's stuff
in this
you're
process.
going to be, and once you're into training and you're dealing with parents and you're dealing with physicians and you're dealing with the parents that says, my doctor said you shouldn't do this, you need to be able to talk intelligently about what's happening and why you're doing these things. I mean, if you showed 75 to 80% of orthopedic surgeons ATG squats and lunges and or Jefferson curls, he'd be like, oh, you should never do that. They need to be educated as to why, and you need to have an understanding of these things as to why it is safe to do them because you're remodeling tissue in the long haul. You're not in a hurry, and so that's why I just want to share these things, because I'm coming at it from two worlds. I'm coming at it from the strength and conditioning world. I'm coming at it from the physical therapy world, and my physical therapy world touches the doctor's world. I'm insulating you guys from the doctors. I'm beating them back at the door and saying, this is good. We should squat. We should deadlift. And now we should be doing Nordics. And now we should be doing Jefferson curls. And everybody should be doing tib work. And it'll solve a lot of problems. So, it's like the guy in high school is friends with 5 groups. He keeps them all from fighting on a Friday night. No, these are good guys. No, these are cool. These guys are good. And that was me too. So I speak to a lot of worlds, man.
Awesome. Yeah, that's essentially what it's about, like listening to others and trying to find the methods that work either for most or work for specific groups, and looking over in German we have this saying, like looking over one's plate, or like the other plates, and not because of jealousy, but like to learn from each other. So
yeah, I mean, it's just so you have little bits of information to take. You just, the more information, the better. And you don't have to know it all. You just have to know where to go and ask. I don't know. I know very little. I know what I know, but I know where to go to find information. If I had a gymnast that was hurt, and I've had tons of them. I actually have some gymnastics equipment up in my gym upstairs at work. I'd hit you up if I had hey, I'm having a kid with a problem here. I'm like, I know this guy overseas. He might be able to help us here. And, and if you didn't know, you'd say, I don't know the answer, but here's somebody that might, what I mean? That's how it works.
Yeah.
I can't be all things to all people. Get nowhere.
Yeah, I mean, this is, for me, this is the big thing what ATG. Oh. Sorry, what did you say?
Oh, nothing.
Okay. It was just for a second. Yeah, I wanted.
You were saying something about ATG. What for you? ATG what?
The ATG for coaches for me is about exactly this thing, like coaches listening to others and like admitting that we might not know everything. And this is like the first step to learning from others. And we have this with these like the fast track presentations. And then, I mean, some might watch the fast track presentation, they hit you up and shoot you a message. And like, oh yeah, this is Shon, he can help me with this problem that I had. That initially I was like just running into a wall, and now I know someone I can ask for help. This is important.
Yeah, and it's important to understand what you're dealing, what's happening to your musculoskeletal system as you go through these progressions. It's what's happening here. It's good that it's just good information to have. It's not something you hang your hat on. A lot of coaches here in the U.S. they'll buy anatomy trains and then everything. I thought I knew a lot about the musculoskeletal system, but I know nothing about it. It's all about this book now. And then there's another therapist in the U.S. named Shirley Sauerman. It's the same thing. Oh, Shirley Sauerman's like an 80-year-old woman who's been a physical therapy professor for like 65 years or 60 years. And these strength coaches take her stuff to gospel. She doesn't even know that world. And she wrote a book, have a couple tests in it. And she's like, I've seen her speak at conferences. She's confused by strength and conditioning people. She has no idea why they want to hear from her. But she'll talk about her principles, but you take them in, you just take a little bit from there. And there's some things that, she talked about the psoas once and how it's multidimensional and has different functions in different positions. And I think that's going to be a nice talk to give when I talk about it, because I think, obviously the psoas is an important muscle in ATG, and there's some good ways to train it. There's some great ways to train it. Talking about with soccer today, soccer players rarely turn on their iliopsoas when they run on the field. They only use their lower hip flexor, the tensor fascial lata, and the consequence of that is a lot of abdominal strains and sport hernias, because they're not able to open up and hit that next gear, because they might not have a great iliopsoas in addition to other things to hit that top gear that Usain Bolt does. He can get that knee flexed. He can get that hip flexed high. He's trained that way his whole life. He's not doing specific psoas training, but the training he does. And I'll show a video of a Sapha-Pal's iliopsoas for an MRI versus a Japanese sprinter who's like literally 3% less fast, and you'll see a massive difference in girth. So there's a whole lot of, don't want to go down the rabbit hole here, but it's happening.
Yeah. I mean, it's a rabbit hole we can dive in, but like maybe one quick addition from me. In general, like, I don't know how you guys think about it, but I recently understood that nearly everything that I learned, I actually learned from other coaches and not from reading textbooks. Not that I didn't read textbooks, but the real understanding and how to apply it often came from the discussion with other coaches, or like kind of going through it again after talking to a coach. And I have the feeling that it's just because once someone adds his own experience to anything, a textbook or reading anywhere, and even if it's like the basic anatomy rules or like principles, they then apply it and they make up their mind, and then they start sharing about it. And this adds like a different layer to the information that's just easier to understand and apply. And at least, like, I think most of us are not actually researchers, but also mainly we're applying it to clients, to athletes, to friends. So oftentimes getting that application layer down might be more important than the deepest understanding.
I totally think that. Yeah, because I hate research. But I don't hate it. It's a necessary evil, but I don't want to do it. I don't want to present it. I want to consume it. But I think we're all doing research every day. Like, we're all doing this thing. And if you keep a constant eye on what you're doing, you say, hey, I made this observation. It's all good. A hardcore researcher would say, well, that's really not, that's anecdotal. Okay. But it's better than nothing. Like, it's better than waiting for the research to happen while the researchers don't even address any of these questions. So,
But also through sharing this anecdotal knowledge with other coaches, it can become evidence, even if it's like just low-grade evidence.
right,
you
and
share- Yeah.
that's exactly right. It might lead to somebody saying, hey, maybe we should look at this in an exercise science study at a deeper level.
Yeah. I think this is going to be like an awesome future for ATG in general, with like just a big group of both athletes in Ben's program, as well as a lot of coaches having enough similarities in their thinking and coaching so that they can communicate about it and share these like findings, experiences to find reasons to start, like, how do you say, starting real research, or like real research, university research.
Yeah, I agree. Yeah, clinical research.
Yeah.
Not basic science, but clinical stuff. Yeah, without a doubt.